Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Your host, Dr. George Netto, is the editor-in-chief of Modern Pathology and the chair of pathology at the University of Alabama at Birmingham. Here's Dr. Netto.
Greetings, ModPath Chat followers. It's my great pleasure today to host Dr. Pavel Dundr, professor and head of the Department of Pathology at the First Faculty of Medicine in Charles University in Prague. Dr. Dundr is an expert gynecologic pathologist with a special interest in ovarian neoplasms. In today's episode, we will be discussing his group's recent publication in Modern Pathology on mucinous tumors of the ovary. Thank you, Pavel, for accepting my invitation.
Thank you, George. It's really honor and pleasure for me, and I appreciate this possibility. So thank you very much.
It's our honor. I'm sure our audiences are going to enjoy learning about this very intriguing study. It's hard for me to believe that we continue to have issues with that. But let's dig in then and tell me why did you want to do this study? It seems like a lot of people were involved, so it's a big study.
I think the purpose was clear at the beginning because those tumors are really difficult to classify. And we are talking about the mucinous tumors of the ovary, but this is a spectrum of several tumors. But the most problematic from my point of view are borderline tumors comparing to mucinous carcinoma with expansile type of invasion. So at the beginning of the study, there was an idea that we will classify this tumor correctly because this is the first step, the gold standard of diagnosis. And then we will perform comprehensive molecular immunohistochemical analysis and try to find some auxiliary markers which will be helpful in the differential diagnosis in daily routine. So it was at the beginning.
So and I like that because really those expansile defining invasion going from borderline to carcinoma based on the expansile are from back in the days where I used to do GYN path, so it continues to be problematic, and that was the purpose. So can you tell us, share with us a few points on the design of the study? How did you go around?
It took me more than 1 year to collect sufficient number of cases, surprisingly from my point of view, because allegedly the mucinous carcinoma of ovary represents about 1%, 1-2% of all cancers of ovary, so it should be easy. But it was very difficult, and I think that the incidence of this carcinoma, mucinous type of carcinoma, is even lower than 1% of all cancers of ovary. So we started to collect the samples from several departments. And then I realized when I checked the slide that my diagnosis is commonly different from the diagnosis under which I received the samples. So we exclude plenty of samples which were clearly metastasis. Then we exclude samples which were endometrioid cancer with mucinous differentiation. And we try to clear all these samples which doesn't belong to the group and have a clear group of mucinous tumors. So this was the first step. And then we collected 124 cases. And this was the group which was supposed to be analyzed later on.
So the cohort was 124, and you're trying to address interobserver variability. So how many observers you got, and how did you show them the slides?
Yeah, we consider as much as observers possible as the best option, because I think that it's really important if your intention is to classify the tumors correctly, because if you have 2 or 3 observers, so then can be really biased. So I decide to address as many as observers possible, and the 14 was a number which seems to me to be okay. So I start with this. And the first idea was that there will be a part of the observers from Czech and Slovak Republic, and the second half from abroad. So either it's my friends and colleagues from US, UK, Romania, Netherlands, Austria, Belfast, and others. So it was really comprehensive concerning these participators. Yeah. So this was the first step, and they agreed. I was very happy about it, of course, because there is plenty of work for everyone, honestly.
That's awesome. So 14 observers is what you start with. And looking at the list, some are, very well-known experts, gynecologic pathologists. But from my prior discussion with you, you informed me that some were not necessarily, fellowship trained gynecologic experts, but that's a lot. They do a lot of that in their daily practice. Is that?
Yeah, definitely.
So
this was the first step, and the next part of your question. So we perform a scanning of this slide. So I selected. It was my responsibility to select one slide from each case. So I check all the slides, and we use the worst slide scenario. It does mean this is the approach to classification of these tumors. So we are used to classify them based on the worst slide and the most serious finding there. So I select one slide from this whole group, and we scan it and place all the scans into the virtual center, and all participants can connect this center either through web client or through some application, and they have 6 months for assessing of this slide. So it was the idea. 6 months was the idea, but later on it took almost 9 months, of course, but it has been expected.
Actually, 9 months is not bad at all. If you gave them 6 and they were going to die, that's pretty good. But so you selected, just to clarify, you selected the worst focus, the worst area, meaning that will really change your diagnosis to either borderline or from borderline to invasive by expansion or what have you. That's what you mean. And that's the slide that you scanned, but then everybody got to see the same, access to the same via cloud to the same slide. Excellent. So I know there is a segment of it that was molecular too. So can you just briefly mention what kind of techniques and
we used DNA NGS sequencing approach. We have here NextSeq, the platform, and use panel, which is our in-house panel for research purposes, which is more than 700 genes. So it's relatively comprehensive. It's about 2 mega per base, so it's sufficient to assess tumor mutation burden and everything other. So this was the first part, and the second was RNA sequencing. We used panel which was close to 150 gene, and we try to search for the most common change based on RNA, and we perform express profiling as well. So 3 approaches: mRNA, RNA sequencing, and DNA sequencing.
Excellent. So that way you cover fusions in addition to expression, and then you did also HER2 by FISH and sequencing in the same time.
Yeah, you are right. So this was another part. There was immunohistochemical part as well, but it was only for the confirmation of the diagnosis, because the goal was to have really clear set of primary mucinous tumor of the ovary. So we exclude all metastasis, as I have mentioned at the beginning, and so on. So immunohistochemistry was only for the confirmation of the diagnosis, but with exception of HER2, because HER2 was as a predictive marker analyzed by this approach, FISH and other.
And we'll come to that. So then that's why let's go next. What were you finding? Did you guys agree on diagnosis, or there was some?
I think it was a bit disappointing situation finally, because the agreement was lower than expected. I hope that we will find that the agreement is great, and there is a short narrow group of tumors which we will be able to classify based on the criteria which we set based on the unequivocal cases. So the idea was that we will improve the diagnostic criteria, and this improved diagnostic criteria will be able to stratify the equivocal cases, which definitely are there. But we failed in this, honestly, and not only based on the morphology, but also based on the molecular findings, because what we have found out was not surprising for some participants, but surprising for the others, and it was that the tumors are really continuum. So this is continuum, and it's very difficult to draw the line which with certainty divide them into 2 categories, which bears really serious clinical consequences. So we failed in this, but I think that it's a first step to improve the diagnostics of these tumors, and I will mention it maybe later, or if there is some time, so I can can discuss our idea. So what was there is that we found out that all mucinous tumors which were classified as borderline tumors behave in our group in benign way. So it was 75 tumors, and we have no recidiving tumor, nothing like this. Then we have group of equivocal tumors which represent 15 tumors from the whole group of 124, and then we have a group of mucinous carcinoma. And in the group of equivocal tumors, we have two clinical events. One patient died of disease, and the second one has recidiving disease. In the group of mucinous carcinoma, we have, of course, much more events, and in the group of borderline, we have none. So the idea is maybe that now we are classifying the tumors not correctly. Maybe the mucinous borderline tumors are in reality, if properly sampled and so on, are in reality benign tumor, and the equivocal category fill the clinical meaning of borderline tumor in the sense that can behave in malignant way, but rarely. So maybe there is the shift in consideration of these tumors, and the shift will improve the diagnostic definitely, because otherwise it's a problematic. Yeah.
So, but I guess I like the suggestion, but even though when you combine cystadenoma and the MBT in one combined category versus mucinous carcinoma, you found only agreement among the experts, absolute, I guess, agreement is what we're perfect agreement, in a little bit over a third. Only 36% you agreed to put in just these two buckets, even when it was, I guess it must have been worse when you were trying three categories, because your kappa is moderate at best 0.52. Is that correct?
You're right.
Yeah, and you don't need to feel guilty. It is what it is.
but it's really and this is the reason why I said that it was disappointing, maybe surprising, because I really didn't expect it that the result will be such a little bit disastrous, because I have here data and I check the raw data from the whole participants, and I model the situation. Then we exclude all the equivocal cases, which represent 12% of cases for 15 tumors. So we exclude them, and then we have set of 75 mucinous borderline tumors and 34 mucinous carcinoma. And if I look at the raw data from each participant, it's her or she diagnosis. So then I found out that mucinous borderline tumors, which were classified based on agreement among all participants, and we arbitrarily set that at least 9% should agree on the diagnosis to classify it into particular category. Otherwise, it was equivocal tumor. So if you
90%, correct?
Yeah. So if you use this, so from the mucinous borderline tumors, which were classified based on agreement of the majority of 9%, so 12 of the participants would classify this mucinous borderline tumor as a mucinous carcinoma. If you look at the category of mucinous carcinoma, so 17% of participants would classify the mucinous carcinoma as a mucinous borderline tumor. And the worst situation was in the mucinous carcinoma with expansile pattern. And there was that if we look at the group of mucinous carcinoma with expansile pattern, so 23% of participants would classify this tumor as a borderline. And I think it's a problem.
That's a problem.
Yeah.
Initially, you said 12% of the participants for the mucinous borderline tumor would classify it as carcinoma. Just to clarify. Excellent. So I'm sure molecular then helped. You did over 700 gene and RNA-seq, and did molecular help?
No.
I'm surprised we accepted this study. I'm joking. As we need to show that where more work needs to be done.
But I think this is reflecting the situation that this is really continuum. This is continuum of the tumors, and we can draw a strict line there, but we can draw a category there, which is risky for the patient. So what was interesting from my point of view, there was only HER2 which was different, significantly different between mucinous borderline tumors and mucinous carcinoma, and the difference was really substantial. I think it was was about 5% for mucinous borderline tumor. And I can see the numbers just now here.
35% for the carcinoma.
Yeah, thanks. For carcinoma. So I think it's really different. And even it was higher percentage for mucinous carcinoma expansile invasion. Correct. So this was different. What was surprising?
That sounds helpful, because if that's a category that give a lot of trouble, and those almost half of them had HER2, right?
Yeah, definitely.
Amplification. And that's 45% of those mucinous carcinoma with expansile. But overall, the carcinomas, 35%, almost a third, and very few, 5% only of the borderline. So it seems like that could be used as a handheld. I know you did also mutation. And by the way, the way you evaluated, just for those of us who don't do GYN, you evaluate amplification is very similar to the breast?
Yeah, we use this criteria, yeah.
Did mutation help in any way of HER2 or just amplification?
Mutation didn't help as an adjunct marker for the classification of these tumors, but I think it's worth to realize that this is potentially influenceable marker due to treatment, of course. So it's predictive marker in these tumors, and I think it can be helpful because we have just now treatment even for patients who had HER2 mutation, not only amplification. So yeah, as a predictive marker, it's good one, I guess.
I think this is a very important conclusion that not only can help you in classifying in that continuum at least, but in the same time, it's obviously a target. Fascinating. This is very enjoyable and informative discussion. And I would like us to end. So the impact, what do you think after you did all this and you waited on your colleague 9 months and we publish it now, what your next mucinous that you have problem, anything different you're going to do or our audience should do?
What we have done, and we are continuing with this, is analysis of p53 mutation and expression there, because one idea was that the borderline tumors slower frequency of p53 mutation and the carcinoma higher. So just now we are analyzing these cases because in our study the percentage was relatively high. It was 43% of borderline tumors with p53 mutation, which is high. And I think it was biased by the relatively small number of cases there, because if we apply the criteria of immunohistochemical expression, so then it was much lower. It was about 30% of abnormal expression if mucinous borderline tumors. And we have very, very tight correlation between the immunohistochemistry and expression and mutation analysis. It was based on the criteria of Kang and others, which was published in your journal as well and recently, and we use this criteria, and we have really very, very high concordance. So I think it's great, and it's one marker which we consider as potentially helpful, but with a percentage between 20 to 30% if mucinous borderline tumor. So I think applying it into the practice is problematic. So what I feel based on the result of our study that we can really classify expansile mucinous carcinoma with certainty, but this is in the cases which fulfill the current criteria and perfectly fit to the category, and this is possible to classify them with very high certainty. The same is true for mucinous borderline tumors. So what's the problematic category? And I think we stress it out clearly that those are the tumors with equivocal features. Those are the tumors which doesn't fit to the category of the neither carcinoma nor borderline tumor. And then we discuss whether there is some possibility to improve the diagnostic criteria, to be more precise, to refine this diagnostic criteria. But the general agreement was that it would be very problematic because once again this is continuum. This is those are tumors which share the morphology, share the molecular features, share the immunohistochemical features. So then it's very difficult to select 1, 2, 3 specific features of this or this tumor. So I don't think this is possible, and practically this requires further discussion about this topic. So I discuss it with several other pathologists, and they are focusing on this topic as well. So we will see.
Hopefully more studies will define that equivocal category, help us. But at this point, not even HER2 or P53 seems like that will make you more equivocal. Well, thank you very much for taking the time and more importantly for conducting such a marvelous study, and congratulations on publishing it. And we look forward for additional submissions from your group. And thank you very much.
Thank you very much, George. It was really my pleasure, and see you hopefully later on.
Thank you. So long, everyone.
Yeah.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Springer Nature, UAB, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. Producers are Christina Crow, Amber Jackson, Dr. Sarah Jang, and Dr. Catherine Ketchum. Technical direction is provided by Kaminsky Productions, music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.